pleasure to welcome Professor Fumi Urano from Washington University. They came last year and again this year, so thank you so much. You must collect millions of jet miles, I'm sure, with all your international travelling. So I really appreciate you coming over with Stephanie Stegobel as well from the SO Foundation. And thank you very much for sharing your exciting research on here. Fumi Urano is really the heir to Alan Permut from Washington University, who first described the gene for Wolfram syndrome, and Fumi is amply fulfilling that legacy by really being the world leader in both Wolfram research and research into endoplazmic reticulum stress. So thank you very much for coming to join us today.
Thank you, Tim, for a kind introduction. It's great to see Dr. Morrison, Patrick, and Dr. Gupta and other patients in the UK. So thank you for this opportunity. So my name is Fumi Urano. Fumi means study in Japanese. I am originally from Japan, but now I practice and do research in the United States. I was trained as a pathologist as well as medical geneticist. And so today I decided to talk about our therapeutic development for Wolfram syndrome. And I take any questions now or later today. So everybody knows, so this is a very important article by Dr. Barrett, published in 20 years ago now. And Dr. Barrett described patients with Wolfram in the UK very carefully, and he discovered that Wolfram is actually a neurodegenerative disease. So this is really an important discovery. And so Wolfram syndrome, there are many clinical challenges, as you know. So urinary tract infection. Are you okay?
Yeah, sorry.
That's another challenge here. Hyponatremia, autonomic neuropathy, headache, anxiety, optic nerve atrophy, and neurodegeneration. So these are all probably all related with the degeneration of different types of tissues by endoplasmic reticulum stress. So in 1998, late Dr. Alan Permut discovered a gene for Wolfram syndrome, and this was really important for us to understand the mechanisms of the disease. So we have been working on Wolfram syndrome. All of you know that most patients with Wolfram develop diabetes mellitus, optic nerve atrophy, hearing impairment, and some neurodegenerative neural problem. And the causative gene is Wolfram. So this is a slide I have been using for in the past several years. We want to develop therapeutics for patients with Wolfram syndrome, and I believe we have 3 steps. And first step is to stop the progression of the disease. And second step is to protect and regrow remaining tissues, remaining retinal ganglion cells, which is really important for maintaining eyesight. If we can protect the remaining retinal ganglion cells or optic nerve, we should be able to maintain the eyesight for long period of time. So that's really important. And then replace damaged tissues. So we know that many patients have lost beta cells and retinal ganglion cells that sustain your eyesight. So this is our strategy for developing treatments for Wolfram syndrome. So I will tell you all of these today and our recent progress. So most of these are all new. So some of the results I showed last year, but I have a lots of updates. So our first step is to stop the progression of the disease using drugs, orally available drugs. And there are 2 options. One is to use FDA-approved drugs. FDA is equivalent to EMA in the UK, so it's a regulatory agency. And so there are many FDA-approved drugs for different types of diseases. And we can use these drugs for, potentially use one of these drugs for Wolfram. So that's one of our strategies. And we are also developing new drugs specifically designed for Wolfram. So we made significant progress in the past 6 months. So I will tell you more about this. So to identify new drugs, already available drugs, we looked for common molecular pathways altered in patients with Wolfram. And this is what we discovered, endoplasmic reticulum calcium leakage. So endoplasmic reticulum is a cellular compartment which is important for maintaining calcium levels in the cells, also creating new proteins such as insulin. So in patients with Wolfram, endoplasmic reticulum is damaged, and that's the reason patients develop diabetes, optic nerve problem, hearing impairment, and neurodegeneration. So we want to block this. So we looked for FDA-approved drugs that can stop this process. And we identified several drugs, and one of the drugs is drug D. I call it drug D. This is really working really well. So, for example, this one, which is the pointer there. Oh, yeah. That's all right. Is there a pointer here? No. Yeah. It's all right. Okay, so for example, the loss of function of Wolfram gene is a root cause of disease. So patients with Wolfram have damaged WFS1 gene, and so if we can induce the loss of function of Wolfram syndrome gene in our cell models of Wolfram, and if we actually deplete Wolfram gene in cells, in brain cells, in the tissue culture dish, these cells start dying. And by giving the drug D, we could prevent this process. And so we wanted to make sure that this drug works in human cells. So we collected cells from our patients with Wolfram syndrome in the United States, and we collected skin cells from many patients, and we turned these skin cells into stem cells. Then we converted these patient-derived stem cells into brain cells. Then we treated these cells with drug D. So the caspase 3 means the cells are dying. So unaffected means control, and proband means patient. So in patients, this band is stronger. This means cells are dying. And by giving this drug, we could prevent not 100% protection, but we could prevent cell death in patient cells. So we are really encouraged by this drug. So we started so-called mouse trial. So we have Wolfram mice. These mice develop diabetes, and these mice develop some balance problems. So we started treating these animals with drug D, and so this is our animal clinical trial design. So 10 Wolfram animals were treated with this drug 5 days per week, and 10 Wolfram animals were treated with just some water. It's called a placebo control. So 10 animals were treated with water, and just in case, we also monitor their siblings, non-Wolfram sibling mice. So this is the result of this animal trial. So by treating So these animals develop diabetes. So by treating these animals with this drug, we could completely suppress their, we could completely regain their beta cell function. So wolfram animals are red. So the number, if the number is high, this means this is the blood glucose levels. So wolfram animals have high blood glucose levels, blood sugar levels. And by giving the drug D, to these animals, we could actually decrease blood glucose levels, which means these animals beta cell functions are regained, or we could block beta cell dysfunction. So this is really encouraging. And so red is wolfram animals, green is wolfram animals treated with drug D, and blue is controlled healthy animals. So by giving drug D, green and blue are very similar, which is really encouraging because these animals almost look like normal animals. So we are really, really encouraged by this result. And so we plan to inject this drug into actually neurodegeneration wolfram mouse model too. So that's our current stage. So, but based on these results, the possibility is to use this drug for the clinical trial. And so it's called proof of concept clinical trial. So it's not a really trial, interventional study, because all the patients may get a drug. So this is an FDA approved drug, and it could be an open label, multi-center and ascending dose study in both children and adult patients, hopefully, with wolfram. And we want to assess the safety and tolerability of drug D in patients with wolfram syndrome. And primary endpoint could be safety, but we plan to monitor beta cell function, gait and balance, your balance, and also your visual acuity and visual fields. So that's the plan. So we are making progress here. So this is about the FDA approved drug. So this drug is currently approved for different disease, but we plan to use this drug for the treatment of wolfram syndrome. So clearly, this drug is not originally designed for wolfram. So we are also looking for new drugs for wolfram syndrome. And so we are making huge progress in this area. So we are very lucky because I visited National Institutes of Health with Stephanie in April, and so that's only 6 months ago. And we explained them about our challenges. We don't have specific drugs for wolfram. No drug company is interested in doing this. Help us, so help us identify new drugs. And very fortunately, we are picked by National Institute of Health in the United States, and they started a collaboration project with my team to develop new drugs specifically designed for wolfram. So it's a three-way collaboration between National Center for Advancing Translational Sciences at NIH in the United States, and my team at Washington University and Snow Foundation. So it's a very nice collaboration, and we identified new drugs for wolfram. I can show you some of the results. So blue means cells are dying. So these are wolfram cells. And so control cell, if you see the number of control cells, it's 500,000. And wolfram cells are dying, so the number is 2,000, it's much higher. And by giving this new drug, we could suppress, with 50 micromolar, we could completely suppress the cell death caused by wolfram gene mutation. So this drug is really good. So I showed the results of drug D, which is currently approved by FDA, and this drug is much better than the drug we plan to use for our clinical trial. So this drug is really good. We have other drugs. So this drug looks good, but we have other new drugs, and we are conducting studies in. We are checking the safety of this drug in animal models. We are also doing PK studies in these drugs, because this drug should go to brain cells. So brain cells and eye cells. So we are doing this right now. So this is a very huge advancement. And hopefully we can use this also new drug. Hopefully we can bring this new drug to our patients in the next 5 years. So really nobody can wait for 5 years. So our plan is to do a fast interventional study with the drug D very soon. That's our plan. So that's for stop the progression of the disease. So two ways: use an FDA-approved drug to stop the progression, and to use new drugs that we are developing together with National Institute of Health. So that's our plan. Then our second step is to protect and regrow remaining tissues. As Patrick just mentioned, if we can maintain small number of retinal ganglion cells, we should be able to maintain eyesight for a long period of time. So even if you have optic nerve atrophy, if you maintain residual cells, we should be able to maintain the eyesight. So we have been working on this very, very hard, and we identified a biologic called MAF. So this is a biologic. So biologic means our cells are creating this molecule, but lower concentration. So what we are trying to do is we try to give this molecule higher concentration of this molecule to patients to protect remaining tissues. So what is this molecule? This molecule was originally purified from human astrocytes, it's brain cells, and it promotes cell growth. It prevents endoplasmic reticulum dysfunction-mediated cell death. And currently, this drug has been approved for the treatment of retinitis pigmentosa and Parkinson's disease. So trials are ongoing. And so we want to use this molecule for the treatment of Wolfram syndrome. So we have developed two different types of treatment based on this molecule. The one is recombinant MAMF peptide. Recombinant MAMF peptide means human artificially made MAMF peptide. So our cells can create this molecule, but very small amount. So we are creating huge amount of this molecule in the tissue culture dish. So it's called recombinant MAMF peptide. And we can inject this peptide into patients. We are also making adeno-associated virus expressing this molecule. So adeno-associated virus is widely used for gene therapy. So we are using adeno-associated virus, and adeno-associated virus expressing this molecule. It's still preclinical grade. And we also have recombinant MAMF peptide, which is clinical grade. So what we did was the following. So we have Wolfram animal model, and so we isolated residual pancreatic beta cells from Wolfram mice. Then we treated these residual beta cells with this recombinant MAMF peptide. And so the number reflects the proliferation of cells. So if number goes up, this means cells started proliferating, growing again. So we treated residual beta cells with this recombinant MAMF peptide, and we could activate the proliferation of residual beta cells isolated from Wolfram mice. So this is really encouraging, because usually beta cells do not proliferate a lot. But by giving this molecule, we could activate the proliferation of residual beta cells. So we also injected adeno-associated virus into these animals. Adeno-associated virus expressing this molecule into Wolfram mice. And these animals developed diabetes spontaneously. So we injected adeno-associated virus expressing MAMF into these animals. After 6 weeks, we isolated we isolated beta cells, pancreas, and looked at proliferation of beta cells. And so this is also really encouraging, because by injecting adeno-associated virus expressing MAMF, we could activate the proliferation of beta cells in vivo. So this is really encouraging. So we are injecting this, so our goal is to activate the proliferation of retinal ganglion cells, actually protect the death of retinal ganglion cells. So this experiment is ongoing. So this is mouth-based treatment. We want to protect retinal. We want to protect the death of remaining retinal ganglion cells using either mouth peptide or adeno-associated virus expressing mouth. So this is our goal, and we are collaborating with biotech company to accomplish this goal. The third is to replace the damaged tissue. Replace the damaged tissues using stem cell-based therapy. So we are making good progress. So we have collected many skin cells. Then we turned these skin cells into induced pluripotent stem cells. So these stem cells can differentiate into any types of cells. So we are making different types of cells right now for future transplantation. And at the same time, we have created a very important group. It's called okay, so this is what we are trying to do. So we collected skin cells from our patients, and we have turned these cells into stem cells. So these stem cells can differentiate into any types of cells. And we are making different types of cells, eye cells, brain cells, and insulin-producing cells. This is ongoing. And so in the future, we want to transplant these cells back to our patients. So to create a clinical grade stem cells and stem cell derived tissues, we created a neurorestorative therapy group at Barnes Jewish Hospital where I work. And Albert is, Dr. Kim is a great neurosurgeon. He decided to work with us to participate in this project. Most of the actually participants are neurologists or neurosurgeons. So we are trying to make GMP grade stem cell derived tissues right now. And clearly, ophthalmologist is one of the group, is one of the participants. So this is what we are actively working on right now. Clearly, it takes time to bring stem cells to the clinic, stem cell-based tissues to the clinic. But we have to start now because it takes time to get the FDA approval, so we have already started. So to summarize, we want to stop the progression using endoplasmic reticulum calcium stabilizers. So we have one good drug, one good FDA-approved drug, and we have several new drugs through our collaboration with the NIH. And the second step is to protect and regrow remaining tissues, especially eye cells. And we have mouth-based therapy. We have a mouth-based therapy, and so this is an ongoing actually project together with a biotech company in the United States. And the third step is to replace damaged tissues using stem cell-derived tissues. Actually, these stem cells are derived from patients' skin cells, so skin cell-derived tissues. So this is our three-step formula to provide cure for patients with Wolfram syndrome. And we have patient registry in our medical school, and we have 150 patients. And so both TIMS registry and my registry have been actually now part of National Institute of Health Rare Disease Registry program. So, and we hope that we get some funds for maintaining the clinic. So this is clearly collaboration, just like my sons collaborate for their soccer team. So many people are working on this project clearly, and funding is from NIH, ADA, JDRF, and from the Snow Foundation. So Snow Foundation is a patient organization in the United States, and Stephanie Snow Gabriel, who is actually, she's here right now, she's here for this conference. And so her daughter has Wolfram, she decided to create a foundation to support research on Wolfram syndrome. So that's, these are funding sources. And so if you have any questions, send me email. Thank you.
Fantastic, Fumi. Thank you so much.
Thank you.
It was really, really exciting to hear the progression of the research. I'm sure there's time for a couple of questions if anybody wants to ask something now. Several. We start at Michael at the back and then Karen. Michael.
Yeah, Fumi, that slide you put up which shows progression of minutes underneath the drug treatments. Could you explain that, the significance of the progression of the minutes, what that shows?
Progression of the disease?
Yeah, no, it's the progression. In your drug trials, you put up two slides which showed had a time sequence along the bottom in terms of minutes elapsed.
Oh yes, that's a great question. So that is a test called glucose tolerance test. So the glucose tolerance test monitors the basically the diabetes progression. So we inject glucose into these animals, then blood glucose levels go up. Then should go down if beta cells secrete enough amount of insulin. So that we inject glucose into these mice, blood glucose levels go up. And then animals respond to glucose, they start secreting insulin. Then blood glucose levels go down. It's called glucose tolerance test. It's also used in clinic. And then if animals, or if we have diabetes or beta cell dysfunction, it goes up very high, then slowly goes down. And if your beta cells work very well, it goes up a little bit, then goes down quickly. And in Wolfram animals, blood glucose levels go up very, quickly, go up very high, then slowly goes down. And by injecting this drug, we could make it lower. So that's how I tested. That's how we tested the drug.
Sorry, there was another question. Karen, yes.
Thank you, Fumi. I was wondering about the mechanism for the mutations in the Wolfram genes causing the disease. Do you think it's the same mechanism that causes the pancreatic cells not to function as the eye cells not to function, as to the neurodegeneration in the disease? Because I can see that it's much easier to put stem cells, say, into a pancreas, or even eye cells into the back of an eye. But my bit of Wolfram, the unsteadiness, the ataxia, the difficulty with the nervous system that goes everywhere, is that going to be the same mechanism involved?
So I believe same mechanisms are involved in neurodegeneration at retinal ganglion cell death and pancreatic beta cell death. The reason is we depleted Wolfram gene in brain cells, and we could see the same defect as we see in pancreatic beta cells that does not have normal Wolfram gene. And we also created stem cell derived eye cells from using patient cells, and we could see the same defect. We saw the same defect as we see in pancreatic beta cells from patients or animal models of Wolfram. So I believe the same mechanisms lead to beta cell dysfunction and neurodegeneration and retinal ganglion cell, I would say retinal ganglion cell degeneration and optic nerve atrophy. And we do have scientific evidence.
Okay, well in that case then, Fumi, thank you very much.